Good morning, ladies and gentlemen. My name is Dr. Gajendran Sivaraja, Emergency MO in Hospital Putrajaya. Okay, it is my pleasure today to introduce our guest speaker for our hospital CME entitled Stroke Network Protocol Activation. Currently, stroke is the third cause of mortality in Malaysia and the leading cause of serious long-term disability in adults. Our guest speaker for today is Dr. Ismail, emergency physician and head of the RESQ Stroke Emergency Unit at Hospital Pengajar, Universiti Putra, Malaysia. The Regional Emergency Stroke Quick Response Unit RESQ is a service dedicated to swift assessment and evaluation together with the neurology, radiology and interventional radiology teams to provide appropriate acute treatment for stroke patients, which includes medical thrombolysis and mechanical thrombectomy. Ladies and gentlemen, please join me in welcoming Dr. Iskasymar Ismail.
Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera to all staff in Hospital Putrajaya. Okay. First of all, I would like to thank you, my colleagues in Jabatan Kecemasan and Trauma Hospital Putrajaya for inviting me to give a talk about our rescue network. We in HPUPM already planned to come to Hospital Putrajaya, but because of the movement control order, so we have to postpone it. Okay. However, luckily, okay, the emergency colleague invite me to come and give a talk about stroke activations in our hospital. The title of my talk today, Stroke Network Protocol Activations. Okay, this is the outline of my presentation. Okay. First, I would like to introduce to all of you what is rescue network, and then what we do in rescue for the management of our acute stroke patients. And then the important things is if Putrajaya want to send a patients to our hospital, so how to activate the team. And then I will talk a little bit about our future plans in terms of ambulance diversions and mobile stroke unit as well. So as mentioned by our chairperson just now, okay, we know that according to the statistic in Malaysia, stroke is the third leading cause of death in 2016. So this is based on the statistic in 2016. So it is the leading cause of adult disability in our country as well. So based on National Stroke Registry in Malaysia, there is a trend, the incidence of stroke is increasing. Okay, if you look at the graph in here, you can see the steady increase in the numbers of stroke cases in our country. So over the last so many years, stroke management always concentrate on the recovery or the rehabilitations of stroke patients. There's not much we can do in terms of acute interventions like we have in myocardial infarctions. But now, over the last 4 to 5 years, there is a significant developments in management of stroke, especially in the hyperacute phase. So there are few landmark trials, meta-analysis that change the management of stroke in hyperacute phase. Examples of studies, important studies, okay, that caused to the significant changes is, for example, is Mr. Clean study, Dawn study, and also Extend study. So now for hyperacute phase, we have two significant interventions that we can offer to the patients. Okay, the first one is intravenous thrombolysis, which already started in the US roughly around 1996. Okay, here in our country, we only started around 2010, if I'm not mistaken, in the Universiti Malaya. And then we also now have endovascular thrombectomy, which can be offered up to 24 hours now. Prior to this, is up to 6 hours, but now due to the recent studies, it can be extended up to 24 hours with the right imaging. For thrombolysis as well, prior to this, okay, if you only have CT scans, yes, the limit is up to 4.5 hours. But if you have advanced imaging, you can extend the time, the window time up to 9 hours. Another significant modalities in management of stroke is having a dedicated ward or area in to treat stroke. In this case, is stroke care units. Okay, if you compare the number need to treat having stroke care unit alone compared to our usual treatment before this, which is giving aspirin and clopidogrel. So the number need to treat for SCU is 28 compared to antiplatelet alone, which is 111. So because of the significant effect of stroke and because of the recent development in stroke management, so we in HPUPM mainly is led by Prof. Hamidon and Prof. Sobri. Prof. Hamidon is our consultant neurologist and Prof. Sobri is our interventional radiologist. We try to introduce a service, what we call a regional emergency stroke quick response network. So the reason we propose this concept is because of the stroke service in Malaysia is still at the suboptimal level. Mainly the limitations because of lack of resources and funding for the stroke care establishment and the management itself. If we compare it to the management of myocardial infarctions, you notice that there's a lot of investments or a lot of development that our government has put into that management. Okay, ada technical issue kejap. Boleh. Okay, boleh continue? Okay, so we propose what we call a rescue network strategy with hoping that the service of thrombolysis, thrombectomy can be made available and benefited more Malaysians. In UPM, we hope to achieve a close-knitted cooperation in between emergency medical services, emergency department team around HPUPM, which subsequently will create an ideal improvised stroke care services to the people. So one of the most important steps in creating a rescue network is to identify lead core high volume center. As I mentioned earlier, thrombolysis services so far is not being optimized, even though it's available. And then in our current setting, the patients in terms of management, okay, for example, going to the city, okay, we have to wait for our turn to have the CT scan. And then due to the fact that the numbers of interventionists in Malaysia are quite limited, based on slides provided by Prof. Hamidon, currently there are around 7 interventionists, okay, radiology interventionists, and all non-neurologists, mainly from radiology. There is an intention to train neurologists as well, like the cardiologists, to become interventionists, but it's still at the planning stage. And then the thrombectomy that is currently being performed is quite infrequent and in isolation. So there is a low impact and not suitable for training. So what are the rules of high volume stroke center for the rescue network? We are hoping to be the lead and reference point for this network. And then after that, it can be a center for research, hoping that with the services which according to international standard, we can reduce the mortality associated with the treatment and the disease itself. At the high volume centers also, we aim to be the training center for stroke, especially in terms of giving thrombolysis services and thrombectomy procedures as well. So we also plan, in rescue, we also plan to pool our resources. For example, having a similar on-call for the interventionists around the Klang Valley. So that is still the plan, not yet executed yet. So as I mentioned just now, in terms of to make this network come to a real, so we have to identify a principal high volume center, and then which also acts as a main training center. And then we are hoping to have satellite centers, which include university or public hospital and also private hospitals. For example, at this moment, hospital Seremban already sent a patient to HPUPM, and in Seremban they have neurologists as well over there. So usually, if Seremban send to us, they either have done thrombolysis in their centers and send it to us for further assessment and possibilities of thrombectomy. We hope we can have a partnerships and as I mentioned earlier, pooling of resources in terms of doing stroke calls, training, drugs, and also some of the expensive equipments like the stands, and also to do rehab. And then after that, hopefully we can expand the concept of rescue throughout the country, and then at the same time strengthen the branding of rescue. I believe KKM has a similar concept as well in their plan with regard to stroke services. But however, I believe we can work together in terms of creating this environment. So what is our plan in terms of implementing the network? This is basically what Prof. Hamidun and our neurology team estimate. During the first phase, at the moment, since UPM is already working, so we are hoping to be the core principal rescue hospital, high volume center. And then, the next step is basically to have a joint call for IR team. And then we are aiming to have 20 trainees and then 200 AVT cases and 500 thrombolysis per year. At this moment, we only have around 16 thrombolysis, 6 thrombectomy, and 9 thrombolysis and thrombectomy cases that we did in the year 2020. After that, we try to identify satellite rescue hospitals, and then we are in the process of working together with Japan Telecommunication Ministry to introduce what we call joint stroke telestroke application apps for mobile. And also we have some close work, some sort of agreement. Try to work together with SOCSO to provide also treatment for semua SOCSO punya pencarum lah. And second phase, we are hoping that we can replicate the concept of rescue throughout the country. So as I said, since we started our services in March 2020, we already offered thrombolysis and thrombectomy to the patients. So we are hoping to be the pioneer principal high volume training center for stroke rescue network. We have dedicated stroke emergency unit. In our hospital, we don't have general ED, but we have dedicated stroke emergency unit. And we have also dedicated bed for stroke patients. And then recently, we already approved for the creations of stroke care units in our medical ward. And we have also a rehabilitation service at HPUPM. So this is the overview of our hospital. Okay, if you can see the red arrow there, that is our stroke emergency unit. Okay, the entrance is at the other end, so the ambulance have to travel a little bit towards the other side of the hospital. So that is the entrance to the rescue unit. Okay, so this is our stroke emergency unit. So I'll just show you a little bit of pictures of our stroke emergency unit. It is, as I said, it's a dedicated stroke emergency. We don't have general emergency departments. So in our stroke emergency unit, we have 2 resus bed, okay, 4 fully monitored bed, what we consider as yellow or observation area. And then we have 1 dedicated thrombolysis room. And then our unit is connected directly to the radiology department. So here, if you can see the arrow, is the door to the radiology department, where we have 1 CT scan and 1 MRI available for brain imaging. Okay, so this is just generally about infrastructure and facilities in HPUPM. We aim to have 400 beds. However, at this moment, only around 70 to 80 beds is actively available for services. And then one of the niche area in HPUPM is stroke services or stroke management. Other niche area, for example, in our hospital is sport medicines and then geriatric. That is our plan in the future. And then, as I said, we aim to treat around 1,500 to 2,000 stroke patients in a year, and then aim to do thrombolysis for about 500 and then 200 AVT if we are fully operational in the future. So we have 25 ICU beds, where 6 of the bed is actually dedicated for neurology or stroke patients. And then we have at the moment 1 angio suite, okay, but we have a very big recovery area for that, okay. And then 1 dedicated thrombolysis monitoring room. Usually in our center, we started the thrombolysis in the MRI or CT rooms. And then after they finish the imaging, we will send to the thrombolysis room, monitored for about 1 or 2 hours. And then we send them either to the ward or to the ICU. Okay, as I mentioned, we have a dedicated emergency unit. Okay, we don't call it emergency department because it's too small. Okay, it's an emergency unit that is dedicated for stroke cases. However, we do see other cases as well, but in very limited way. Okay, for example, any post-op patients from our centers can be admitted through the stroke emergency unit as well. So when we have dedicated emergency departments, so there is no delays in competing with other emergencies. So far we have only 1 CT and 1 MRI and 1 angio suite. However, when there is acute stroke patients, this patient will be prioritized compared to other patients. And then by having dedicated emergency units, we able to create a closer working environment among our emergency medicine team, neuromedical team, neurosurgical team, and also the IR team. So this constitute the acute stroke team, which I'm going to talk a little bit more later. So just to show you some of the pictures, okay, on the right side, okay, when we receive call from other centers, usually the neurology team will come down immediately to the stroke emergency unit, okay, and then we have the rest is the stroke emergency unit team, okay, which consists of MOs and then few of the paramedics. Okay, the pictures on the left is one of our first thrombolysis room. First thrombolysis patients. Okay, we thrombolize the patients and monitored in our dedicated rooms. And then one of the pictures shows one of the patients that we received from other medical centers, and the other pictures is our IR team. Okay, before. So what we do in rescue, okay, it is a 24-hour services, okay. We do thrombolysis even in the middle of the night. We even do thrombectomy 2 o'clock in the morning. So we have few cases that we did thrombectomy early morning during the day. So we accept any walk-in patients, okay. Between December and November last year, we received 15 walk-in patients, 24 referral from other hospital, KKM hospital, and then we received 2 referral from private medical center. So far, in terms of ambulance diversions, we haven't received so much cases yet. As far as I can remember, since we opened in March, we only received 2 ambulance diversion cases from Sedang ambulance team. As I mentioned, when we have acute stroke, all of these personnel will be waiting in the stroke emergency unit. So usually there will be the stroke emergency unit staff consists of the EP, medical officer, and paramedics. And then usually we will be joined by one of the specialists from neuro or medical team, and they are one of their MOs. And then the interventional radiologists or radiologists also will be around when we do the imaging, okay, because we will make joint decisions whether to go ahead with the interventions, either thrombolysis or thrombectomy. Even though our main reference will be Prof. Sobri and also Prof. Hamidun in terms of to go ahead, whether to go ahead with the treatment or not. Okay, we have what we call 2 types of stroke code. Okay, for example, if you referring a patient which have stroke symptoms or signs which onset is within 4.5 hours, or sometimes if we only know that their last known well is 9 hours ago, then we're going to activate what we call stroke code rate. So this kind of patients, it is possible to thrombolize together with offering thrombectomy to them. Okay, it can be either thrombolysis alone or thrombectomy alone, or a combination of thrombolysis and thrombectomy. And then we have stroke code yellow. Okay, if the onset or last known well is between 9 hours to 24 hours. In this group of patients, okay, it is possible to offer thrombectomy to the patient with the advanced imaging that we are able to do. We also accept any cases beyond 24 hours. Okay, basically all the patients red or yellow or beyond 24 hours of onset. Okay, when we admit the patients, okay, we have our neurologists to manage the patients. We have our rehab team also to manage the patients. So they will monitor the complications, optimize the risk factors, and investigate underlying causes. Okay, this investigation include a more detailed MRI and some of other imaging like Doppler ultrasounds. Okay, so most of the time, okay, in our center we do MRI imaging. Okay, almost 90 to 95% of cases we do MRI as our imaging. Okay, with MRI, we can extend the windows up to 9 hours. If you only have a plain CT scan, then the windows is only up to 4.5 hours. But with MRI and CT perfusions, we can extend the windows up to 9 hours. So usually for those who wake up stroke, what we call wake up stroke, when they wake up in the morning, immediately notice to have a stroke symptoms. Okay, when we do MRI, we can see. Okay, for example, like in these pictures, this white dot on DWI imaging and the black dot in ADC near the ventricles there. So this confirm the evidence of acute stroke. Okay, if we don't see these two changes, at least we don't if they come within 4.5 hours and have a certain NIHSS, but they don't have these changes, we don't thrombolyze. We have one patient that is being referred from Sedang with stroke symptoms. Okay, when we did CT scan, when we did MRI, there is no acute changes. So when we re-examine the patients after MRI, we notice that the patient is actually mimicking the signs and symptoms. So we basically treat her as a stroke mimic. Okay, even though the NIHSS is within the range and she come within the time for thrombolysis. We can extend to 9 hours if we do flare protocol in our MRI. Okay, if you can see the white dot in flare and DWI, okay, here, then we call it match. So match means that yes, there is acute stroke, however, it is already established, perhaps more than 9 hours. So if we see these changes, we don't thrombolyze. However, if there is a mismatch, white in the white area in DWI, but there's no similar white area in the flare, then we might thrombolyze the patients if they are NIHSS within the range. Okay, we do SWI just to have a look whether there is any hemorrhagic changes as well. Okay, if you then part of the imaging also we do MR angiogram. Okay, if you see the blood vessels in the MRA, okay, on the right side, on the left side, okay, it is not symmetrical to the other side. So this indicate there is a large vessel occlusions, which if we find this and we do a little bit more imaging, and then the interventional radiologist together with the neurologist will decide whether this patient is eligible for thrombectomy. So if we do MRI, we can do the MRA without any contrast. If the patient has CKD, then we can avoid causing further damage to the patient. Okay, so far, okay, this is the audit that we did from March until November 2020. Okay, so far we have done thrombolysis, 20 thrombolysis up to November. Okay, and then thrombectomy 11, and then combinations of thrombolysis and thrombectomy is around 6 patients. Okay, our KPI, we aim to send patients to imaging within 20 minutes. So far, based on our audit, we managed to get to the radiology department within 15 minutes. At this moment, we just put our KPI for door to needle as 60 minutes. Okay, so far we achieve it within 40 minutes. However, in the future, we perhaps will push ourselves to reduce the door to needle time even further, so that we can administer the thrombolysis quicker. For thrombectomy, the aim is to do it within 90 minutes. Okay. However, in our center, we notice the main challenges to achieve this target is mainly because of the payment. Okay, I will talk about the payment, the cost of the treatment later on. So this one of the challenges is to achieve the target time is because of the cost of the treatment. Okay, just to show some of the pictures, the thrombectomy done by our IR team. Okay, if you can see the left image, okay, this is pre-thrombectomy, and then after that, after the intervention, you can see the flow in the blood vessels in our brain improve. And then we have another mode of imaging as well in the angio room, okay, to see the restorations of the blood flow at the perforators level. So this is one of the examples of cases that we did. Okay, so it is successful in terms of reperfusing the brain blood flow. Okay, people all ask what is the cost. Okay, I believe all of you are aware that we are university hospital under a different kementerian. So we have slightly different fee structures compared to KKM hospital. For all patients with government guarantee letter, if you are indicated to have thrombolysis, almost everything is free. Okay, if you don't have the government guarantee letter, then the cost of having thrombolysis in HPUPM can range between 3,000 to 6,000. It depends on the imaging and also the drugs. Basically, mainly the cost is from the imaging, because MRI costs around 800 ringgit. Okay, and then some of the blood investigation also we charge the patients. But for the drugs, we don't charge the patients. The drugs, for example, we use Altiplase, it costs around 4,000 to buy the drugs. We also use tenecteplase. Okay, tenecteplase we use, the preparation is for MI, for treatment of MI, but we also use tenecteplase as an off-label indications. So we have to get an extra consent from the patients if we want to use tenecteplase. Okay, based on meta-analysis of in 2020, okay, tenecteplase is almost equivalent in terms of the effect and the benefit compared to alteplase. It's not less inferior. However, it's still not part of the indication to use tenecteplase. So it's considered off-label use. So we have to get extra consent. So for thrombectomy, if you are a government servant which has GL, okay, then you have to prepare at least 17,000 to 20,000 ringgit to have this treatment. Okay, it is similar in UKM and also in UM. So even if the UPM staff goes to hospital UPM, they have to pay this 17,000. But for those who are already retired, pencen persekutuan, okay, pencen persekutuan, somehow they have a specific fund for this treatment. So if you have people, if the patient is orang pencen persekutuan, then all the treatment will be free. Okay, but for those who don't have GL and pencen persekutuan, the cost is around 20 to 25K. The last patient that we treated, okay, the total charge the patient have to pay, including ICU care and also the ward care, is around 35,000. However, if we compare it to the private center, okay, to have thrombolysis and admissions, it will cost you 20K. And then to have thrombectomy plus minus thrombolysis and admissions to the ward, it's going to cost around 60 to 100K if you go to the private center. So we are still cheap, but it's still a challenge, okay, especially for thrombectomy when they have to give a large amount of money before we can proceed. And one of the reasons why we cannot achieve the 90 minutes KPI target that we set for ourselves. However, we have planned in terms of providing aid to the patients to cover the cost of thrombolysis, which I'm going to talk a little bit later on. Okay, so we already know what rescue can offer. So how can you refer to us? Okay, basically, we accept any cases that exhibit any stroke sign or symptoms. Even TIA, we also accept. Okay, we also accept, as I mentioned earlier, stroke that are more than 24 hours. Okay, this is what I propose in our what I propose for other ED to do. If you have a stroke less than 24 hours, okay, at the triaging area, okay, hopefully the triager can know how to do some screening tests. For example, do a fast test in the triage. If it is positive, at least send to the yellow zones. Okay, in the yellow zone, quickly hand over to the MOs in charge. And then if the MO in charge do a little bit more assessment and reconfirm the findings of the triager, please immediately have a discussion with the EP in charge. Then the EP in charge can refer to the emergency physician in rescue. Okay, don't need to talk to the neurologist. However, if it is more than 24 hours, you can consider referring to the neurologist in HPUPM. Okay, we use WhatsApp and also special applications, what we call joint applications developed by the Japanese for mainly for stroke cases. But so far, people the other clinicians prefer to use WhatsApp rather than the joint apps. It is similar like the STEMI network, where they try to develop special apps for our STEMI network. However, people are more comfortable to use WhatsApp. Okay, so so far we have WhatsApp group together with Hospital Kajang. Okay, and then we try the joint apps with Sadang Emergency Department. So basically, it almost similar. The function is almost similar. only that the joint applications we can directly upload the CT or MRI images into the applications, and we also able to time noted the time when the patient arrive, when the patient go to CT scan, and when the patients have the interventions. So usually during office hour, it is easily answered by any of the EP in the groups. Okay. However, if you don't receive any response within 5 minutes, please call the EP on call. Okay. We will provide. Okay. If we have an agreement, we can create a joint WhatsApp group or joint group, which include all the EPs, including Kajang, Sedang, and Hospital Putrajaya, like the STEMI network group. And then it can be joined by the physician as well. Okay, you can activate the team through this. However, if they don't respond within 5 minutes, okay, we're going to provide this roster. Okay. Usually, we, the emergency physician, will take the call, and then we're going to quickly discuss with our IR and neurologist team. And then if they are okay, usually within a few minutes, we can make a decisions. Sometimes if it is a clear-cut cases from the emergency department or from the ward, even the ward, okay, I myself will immediately accept the case when somebody call me. Okay, so the EPs will take the referral, okay, and then we're going to activate our team in the hospital. Okay, so if you call us, okay, we are hoping to get some information about the demographic, the onset and last known well will decide whether it is stroke code red or stroke code yellow. And then we want to know a little bit about the symptoms, because we can anticipate what kind of vessel is involved. We want to know the ABC status so that we are not surprised when the patient arrive. Patient need to be intubated, for example. Okay, we have one cases from one of the private center referred to us when the patient arrived, patient GCS low, okay, and they have thrombolyzed in that hospital. Somehow patient have bleeding complications, and then somehow the patient doesn't know that they have to prepare a few thousand ringgit for the treatment. So end up we have to send the patient to Sedang because patient cannot afford, and then patient have a lot of other complications. Okay, kalau daripada hospital rehabilitasi Ceras, okay, if you want, if you have the information, we can share as well the numbers of the EPs or the roster of the EP. Even we can share the numbers of our neurologists as well, if you are more comfortable to talk to them. Because some cases, perhaps especially if it's more than 24 hours, okay, sometimes we have to look at the bed availability as well. Okay, but at this moment it is okay because we have a lot of empty beds. So we can share this information for those who require. Otherwise, you can either call me. Most of the time, I will answer the phone. If it is stroke, I will activate my stroke emergency unit team and also our rescue stroke team as well. So this is how you activate. Okay. So this is basically a transfer from one medical center to the other medical center. Do you need to do CT scan before sending to us? For us, it is better for you to send after clinical assessment, straight away send to us, because as I said earlier, we are going to do advanced imaging to immediately decide whether for thrombolysis and also thrombectomy. If you suspect it's going to be bleed, yeah, it's up to the clinician who treat the patients. Okay, because sometimes when you send a patient with stroke, okay, most of the time, sometimes we do not know whether it's hemorrhagic or ischemic. If it is hemorrhagic stroke, end up patient having hemorrhagic stroke, at this moment we can directly consult our visiting neurosurgeon, Mr. Rahmat from Seremban, to decide whether this patient needs surgical interventions or not. If they don't need any surgical intervention, basically medical management, we will admit the patients. If the patients require neurosurgical intervention, usually they will be sent to either HKL or Seremban. Depends on the neurosurgeons on call at that particular time. So at this moment, we don't offer any neurological management, neurosurgical management. However, we are in the process of bringing one neurosurgeon to our centers and having the equipments to do neurosurgical procedures in our HPUPM. Okay, a little bit about ambulance diversions. Okay, I believe in the near future, we're going to have a meeting with KKM representative, mainly Dr. Khairul, Dr. Koswadi, and EPs from the nearby hospitals. We're going to hopefully we can have what we call ambulance diversions. If the ambulance 999 call goes to the community, and then if they detect stroke, okay, after doing some screening, okay, we are hoping that the patients can be diverted to us instead of going to the usual hospital. For example, if we respond in Putrajaya, if we know it is a stroke, get the medical directions from the EP on duty, so that ambulance can be diverted to the HPUPM rather than go to Putrajaya first, see in Putrajaya, and send to the HPUPM. However, there is extra questions that the pre-hospital care team have to ask. Okay, so this statement is from our latest ischemic stroke guideline, CPG, which just published, I think, a few weeks ago. So 2020 ischemic stroke CPG, Malaysian CPG. So in that CPG, we put for ambulance diversion to have, we put one of the guideline is to divert the ambulance to a stroke-ready hospital. Okay, before they arrive to us, hopefully they can provide pre-arrival notifications, mainly the onset, some of the vital signs, and then do some blood sugar, so that we know which stroke code to activate. So if it is stroke code red, then immediately all the teams will be ready in our emergency unit, and then try to do the assessment as quickly as we can, and then try to institute the treatment as quickly as we can. So this is just a flow that we see. Okay, basically we need to educate the public in terms of identifying stroke. In MECC, I believe there is already a available protocol to identify stroke, so that it can be given high priority dispatch. So when the pre-hospital team goes, they do some screening tests, okay, make sure ABC is okay, check glucose, and then hopefully they can divert to the stroke-ready hospital. If somehow they are unable to identify, we can still accept patients that is being transferred from other medical center or emergency department. And then we do what I just explained just now. Okay. Extra things that need to be done by the ambulance pre-hospital care is basically do some stroke screening tests, for example, FAST or BFAST. BFAST is difficult to do, but can do at least FAST. And then take note the onset is especially if it is less than 24 hours. And then one more extra questions like the question that need to be asked by the emergency physicians or the medical officer in ED is whether patient agreeable to be transferred to our center, mainly because of the different fee structure. Okay, if yes, then MECC can coordinate and inform us of the possible arrival of patients direct from the ambulance to our door. Okay, so far we only have 2 ambulances already in service. Again, hoping once we have a discussions with Dr. Khairul and some bahagian perkembangan KKM, we might able to take part in the pre-hospital care response. Okay, if the 999 call, the MECC able to detect it is stroke. If it is within 15 kilometer, that is our plan from HPUPM, we might be able to respond directly to the stroke cases. If they don't want to come to HPUPM, we will send to the nearest KKM hospital. And then we also plan to retrieve patients from nearby ED using our ambulance once we have the proper manpower. Okay, so far I've tried to retrieve patient from Sedang because it's just next door. Okay, we can from activations to arrival to our door is around 25 minutes. And this is our future plan. Another future plan is to have what we call mobile stroke unit. Okay, bear in mind in Thailand they already have 4 mobile stroke units. So far we don't have anyone. Prof Hamidun aim to have 1 mobile stroke unit in HPUPM. So far, 4.5 million ringgit has been allocated from our budget given by the government to have this unit. We are hoping 2022 or 2023 we're going to have this mobile stroke unit. Basically, we can CT scan the patients in the community and decide, okay, through telemedicine, decide whether we can thrombolize a patient. Okay, last slide from me. Okay, in terms of funding, okay, we are creating tabung kebajikan HPUPM so that some of the money from this tabung can be used to fund the cost of treatment for those who require it. We also create tabung wakaf HPUPM for these purposes as well. So we already in talk with some NGOs. One of them is One Hope organizations. This organization is actively involved in funding, okay, for those who cannot afford it in Penang. So one of our neurologists already come into contact. So we're going to create an MOU with One Hope organization for those who are eligible, basically B40 groups who are eligible. They can have some sort of a donation from these organizations and can have all the treatments that I mentioned free. The money is provided by the organizations. We are also in talk with Pekeso or SOXO. Pekeso is trying to make a decision whether the stand can be considered as part of their some part of the device that they can sponsor, so that all the SOXO, pencarum SOXO can have the thrombectomy without paying the 17 to 20,000 cost. Okay, I think that's all from me. Okay, if you have any questions, if I can answer it, I will answer it. If not, I will try to get consultation with my senior neurologist and IR, and then get back to you. Thank you very much.
Assalamualaikum. Can I have a question?
Yes.
Okay, sorry, Rafidah here. I'm the physician, nephrologist. I think thank you so much for the wonderful setup that you've done in UPM. I think for those who I don't know whether you do know, I'm a very proponent of thrombolysis, and I think I started the service in Temerloh last year, which is going on quite well, despite not having neurologist or neurosurgeon in situ. So I cannot we've also medical department also engaged with Prof Hamidun as well. Thank you so much. I think we are starting to refer cases to them, and they've obviously lies quite nicely. My question is not question lah, probably a more of a statement. I think this financial issue, I don't think we're gonna be able to sort this out, even in the next year. I'm look, and I think one of the neurologists have presented, I think Prof Hamidun and team have presented to me about the One Hope. I think that's good, and now today you're telling me there's tabung kebajikan and all that. I'm more than happy to actually help to actually get funding for that lah. The other thing is, are you all considering like a special budget through the MOE, through maybe Treasury, specific funding for management of patients? Maybe that will be another thing, because I personally don't see it through this budget thing within the KKM structure. Thank you very much. Maybe some response from you.
Okay. All right. Probably I cannot fully answer the questions, but from my discussion with Prof Hamidun, he and few other neurologists through MSN, the Neuroscience Society have engaged with I think the top management of KKM to support the initiative in terms of payment, in terms of supporting the cost for thrombectomy and thrombolysis. However, I'm not sure to what extent the agreement has been achieved. But yes, we have already talked to KKM about it. Okay, because if you notice, I think the cost between for reperfusion therapy for myocardial infarctions and stroke almost we can say almost similar, even though perhaps at this moment mungkin for stroke is much more expensive. If we can get a similar commitment from the government like they have in terms of management of MI, if we have similar emphasis on stroke, I think we can achieve it. But as you said, it's going to take time. So what we are going to do in this moment is we try to get the MOU with One Hope as quickly as we can. And then in terms of tabung kebajikan and tabung wakaf, it's still slow, but we are hoping it can progress very well.
Thank you so much. Well, I think I will contact the tabung wakaf. Maybe we can help, promotion and awareness and funding for that. Thank you.
Okay. Yeah, you can call us, and then I will connect you to the relevant people. Okay. Any more questions? Okay, kalau tak ada, I hope you can consider sending a patient if they are willing to come. Okay, we're going to try and help as much as we can in terms of managing the stroke patients. Okay, thank you very much for your attention. Hope to see you in the future. Thank you.